Good afternoon, everybody. Thanks for joining us today. This is Nick Perkin. I'm one of the principals at Advance. I'm going to introduce Delane Henry, our CEO, today, but just wanted to first thank all of you for joining us today. This is one of the better attended webinars I've actually ever seen, so thanks for all of you for participating. Over the last 15 years, Delane has been involved in everything from starting new hospices to coordination of billing and revenue cycle management procedures at larger ones. She's an expert in risk management in terms of understanding revenue cycles, and she is one of the top billers we've ever come across. She also leads our hiring practice, so finding some of the top billers in the country to join our team at Advance. So thank you all for coming today. I look forward to passing this off to Delane, and she'll run you through this presentation. So thank you very much for joining, and Delane, all to you. Thank you.
Thank you, Nick. I appreciate that. Good morning, everyone, or good afternoon. I appreciate everybody joining as well. And today we'll talk about the hospice final rule. I think the most important thing that I've learned when studying the final rule and discussing it with other consultants is that it's somewhat confusing in some of the components, but we'll run through it, and I'll be happy to take any questions. If we don't get to all the questions, I'll be happy to answer those on email. So we will keep a list of all the submitted questions, and we'll respond. If anybody would like to have a complete Q&A list, please email me, and we'll make sure that you get a copy. First, I'll talk a little bit about advanced hospice management for those of you who maybe are not familiar with our company. We're a hospice-only, third-party independent billing solution. Our billers are dispersed across the country, which really allows us to have some redundancies in coverage. Every one of our clients has a primary biller, and that biller is available to you when you need them. However, there is always at least one backup, and the collaborative team participates in backing up each of the billers as well. So for our clients, there's the added comfort of knowing you have a dedicated biller, but you always have a backup. We have a 24-hour emergency hotline for any types of issues you may come across that are not 9-to-5 issues, which we all know those happen. Our focus is customer service, education to not only our clients but our billers. You know, our primary goal is to maximize your collections, and we do that by hiring the most skilled and experienced, highly trained billers from across the country. So today we'll talk about the CMS changes. You know, what will CMS do with the data they're collecting? I'm sure you guys have seen that the final rule includes some additional process measures and some discussion about some further reporting. So as anything that affects billing or reimbursement, that's important to us because it's important to our clients. So we're going to address the final rule and all of the different components. So the 2017 final rule updates the Medicare hospice payment rates, the hospice wage index, and the cap amount. The estimated $2.1 million, which is a $350 million increase in Medicare payments for 2017. Now that applies to all agencies who are following their hospice quality reporting program and meeting those guidelines. For those of us who are not meeting those reporting guidelines, our increase for the year is only 0.1%. So basically, those agencies will stay flat. This final rule also describes a potential future enhanced data collection instrument, which may translate to some of you who have home health experience as something like an OASIS, possibly. The publicly displayed quality measures and other hospice data beginning in the middle of 2017, which I think I've seen the target date somewhere around April. And it'll include information regarding the Medicare Choices program, which I'm not sure that all of you guys are familiar with, but that is something we haven't addressed in our slides, but I'll be happy to send more information to anybody who would like more. I know it's a pilot program, not everybody is participating. So the national rates from 2016 to 17 look like this. Day 1 through 60 goes up from 186 to 190 basically. Day 61 forward goes from 146 to 149. Our SIA payments, which are paid at the continuous care rate, go from $39.37 hourly to $40.19. GIP from $7.20 to $7.34, and inpatient respite from $167 to $170. For your particular agency rates, we've included a link to the Medicare website that'll give you all of your CBSA links for your case mix rate. For your wage index rate. Now, for those of you, again, who are not meeting your quality reporting guidelines, you essentially remain flat, and you'll stick with those 2016 rates with a 0.1 increase, which, of course, with hospice operating on the margins that it does, I don't know that anybody can afford to not be meeting those guidelines and submitting all your quality data. I don't know that anybody can give up that 2%. And, of course, we all know that the sequestration, the 2% reduction rate has no end in sight. So we've already lost that 2%, and here's an opportunity to kind of wash that 2% loss. So we certainly don't want to lose it by not reporting. The annual data submission requirements are different for every year. 2016 requirements, 2016 requirements, which were 1/1/16 to 12/31/16, obviously. We are required to have 70% of all HIS records submitted and meet the 30-day deadline. For 2017, that will move to 80%. Our HIS requirement is 80% of our records submitted and meeting the 30-day deadline. From 1/1/2018, Medicare expects that 90% of our HIS records will be submitted in the 30-day time frame. So, honestly, if we already have a process in place and we're submitting our data, there would be no reason why we couldn't now be at that 90%. That should be our goal. Everyone should be working towards that 90% so that when we hit that deadline, we're already there. We shouldn't have to be working up to that goal every year. And that will keep your any annual increase in rate safe from those penalties. So let's talk about our new hospice quality measures. Again, there are two new measures, and the first one has two components to it. So the first one, hospice visits when death is imminent. That is our first measure, and it is broken down into two parts. And the first is that it's going to assess the percentage of patients receiving at least one visit from an RN, a physician, a PA, or a nurse practitioner in the last 3 days of life. The second is going to assess the percentage of patients receiving at least two visits from a social worker, a chaplain or spiritual counselor, an LPN, LVN, or a hospice aide in the last 7 days of life. So that's one measure, is what are we doing for our patients at the end of life? And I think what's important about that is they're measuring, are we providing the care to the patient when the patient needs it the most, when the family needs support, when the patient needs it. And so they've given us this SIA payment in the last 7 days. They're saying, hey, guys, we will give you additional reimbursement for the visits, for those qualifying visits in the last 7 days. So now they're tracking to see, are we making those visits and the additional types of visits? Are we providing the care that benefits the patient the most in that time of crisis or need? So the hospice and care composite measures, they remain the same. Those 7 measures remain the same. But now they want us to give them the information about whether or not the patients are getting those processes. So they're trying to give us this information. They're trying to get us to give them the information about whether or not we're implementing care with regard to these process measures. Up to this point, they've just collected this data, but they're not using it for anything. They're not actually compiling it. They're not using it for anything, any type of outcomes, or are they compiling it? No. So we believe that the implementation of the service intensity add-on, it represents an incremental step toward encouraging higher frequency of much-needed end-of-life care, which is what I was just saying. They're trying to make sure that they are incentivizing us to provide that care, because the goal of the hospice payment reform changes is to more accurately align our hospice payment with resource utilization while encouraging appropriate high-quality hospice care and maximizing beneficiary, family, and caregiver satisfaction with care. So what are we doing with the data? Along with these new process measures, there's additional data collection that's taken place. And up until this point, the HIS admission and discharge, the only requirement was that we report it. There was no requirement for content, and it wasn't used for any kind of outcome, and there was no consideration for the data given. But that's going to change. So now Medicare is also collecting this additional data: percentages of Medicare beneficiaries electing hospice, the total number of Medicare hospice patients. I mean, you guys can go down the list. I think one of the most concerning is the number of live discharges, because that is a hospice election. That's a patient election. We can't control, that's not in the hospice's control if the patient elects to revoke their hospice benefit. So how they'll use this information and how it will affect what will eventually become hospice outcomes on a hospice type compare site, it is definitely a question. Now they're also discussing that hospice assessment, an additional hospice assessment that would, along with providing the HQRP and the HIS requirements, it would add additional clinical data that could be used in the future for rebasing our hospice payments. So I put in an OASIS anyone because I'm sure all you guys out there with home health experience know exactly what happened in home health, the change that went from a per visit payment to the PPS reform into the OASIS scoring, and how that has evolved over the years since 2000. So the question is, is that where hospice is headed? Is that what Medicare is considering? And maybe it's a version. I'm not sure that it will be exactly like home health, maybe not at all. But when you see them collecting data, everybody has to speculate about where eventually that data will be used. So I think it's really important that we consider how accurate our data is, and that we consider it for the whole clinical record, not just what maybe we see in a list of things that they may be compiling, but that anything that could possibly affect how you're reimbursed and how they determine patient need and how they're looking at groups of diagnosis and different things that are impacting hospice length of stay and all of the things on our list. What the most important thing is that we make our clinical record accurate, so that this data Medicare is compiling is accurate. So in the future, we're not looking at a new rebased hospice payment system where we're questioning why Medicare chose to maybe pay us more or weight certain things more, certain clinical aspects than others. But if we're not giving them all of the complete and accurate data that they are going to use in the future, then we're really kind of shooting ourselves in the foot. So I think all of the HIS and all of the public reporting and all of those things are extremely important, obviously. But it's also important to make sure that we aren't disregarding, not focusing on the entire clinical record of the patient that Medicare sees. Because keep in mind, they're not tracking up your diagnosis codes other than to tell you how many Alzheimer's patients we treat annually, how many cancer patients we treat annually. But we know that information goes over on the claim, so they have the information. Will they use it maybe against us later because there's like half of claims, maybe not quite half of claims, we're still going over with one diagnosis. So I'm kind of going off on a tangent here, but what I'm trying to point out is that when our data is accurate, then our payments should follow, and we should be accurately reimbursed for the care that a patient needs based on their clinical condition and not based on inaccurate data that we maybe submitted because at the time we weren't focused on it and didn't realize the importance of it. So CMS has indicated the expectation to begin public reporting of hospice quality measures using a hospice compare-like site in the spring of 2017. And from what I understand, they'll be using the last 4 quarters of data. Now, I do understand that there are preview reports, and hospices will have time to review and correct their own data. And there are 2 types of preview reports that will be available in CASPR. And the results will be for public reporting, and there's provider-level feedback reports as well. So you definitely want to get on the CASPR, you want to pull your PEPR reports, and you want to look at these reports that you can preview and determine if your data is accurate and if any corrections need to be made. So that's actually our full presentation. Again, I know I did not touch on the Medicare Care Choices model, which if anybody is on that program, I can tell you that basically what it does is it provides, it's kind of a link between palliative care and aggressive treatment. It's a little bit more streamlined as far as how the process works, but if anybody has questions about that, I certainly have data from Medicare that I'd be happy to share, and I'll send out links to that. So if anybody has questions at this point. If you guys would give me just a second, I'll go through the questions. Okay, everyone. I seem to have a little bit of a problem getting the questions. I do see that there are several people who have asked if we will give out the slides, and absolutely we'll email the slides out for you guys, and also some other links for the information that I've shared and where the reference material for where I got the information. And again, what I think will work best is we'll pull the questions, and I'll do a Q&A in a written format, and I'll send that out as well. And you guys can email us if you have any other questions. I'd be happy to answer those for you. So please use the email address on the bottom of the screen on our last slide, dh@hospicemgmt.com, and I'll be happy to send out this information and anything else that I have that I think will be helpful. So I appreciate everybody's time. Thank you so much for joining us. And if you have further questions again, please reach out. We'd be happy to speak with you. Thank you guys so much, and everybody have a great afternoon.